Assalamu alaikum everyone. Our next topic of discussion from first aid renal pathology is the kidney stones. So how kidney stones are formed? They are formed when substances in the urine like calcium, oxalate or uric acid, they become too concentrated and they crystallize, forming the solid masses. These solid masses then aggregate, growing into the larger stones, causing pain and blocking the urinary tract. So the complications of kidney stones include hydronephrosis, pyelonephritis and acute kidney injury. What will happen that if there is a kidney stone here obstructing the uretropelvic junction, it will cause backflow of the urine towards the renal pelvis and the calyces. That will cause the dilatation of renal pelvis and calyces, forming causing hydronephrosis. And when there is stasis of the urine, it will cause infection, pyelonephritis, and there will be sudden decline in kidney function, causing acute kidney injury. The clinical features of this stone include unilateral flank tenderness, colicky pain radiating to groin region, and hematuria. So, the characteristic feature of the kidney stones is the colicky pain or crampy or waxy or venning pain due to the obstruction of the lumen of the ureter, and that it will be radiating to the groin region. There will be hematuria due to damage of the ureter by these stones, and there will be unilateral flank or costovertebral or loin region tenderness. And the treatment and prevention includes in encouraging the fluid intake, because stones are formed when there is increase in concentration of the solutes or decrease in the fluid intake. These solutes then aggregate and precipitate to form the stones. So if we want to treat the or prevent these stones, we have to increase the fluid intake of the patients. We will encourage the patients to increase their fluid intake so that they can dilute the concentrated solutes. The other clinical features include nausea, vomiting, or ileus. Ileus means that there will be no bowel sounds. If we see different types of stones, there are four main types of stones, that are calcium stones, ammonium, magnesium, phosphate, uric acid, and cystine stones. Among them, the radiolucent stones are cystine and uric acid. We can remember them by the mnemonic "I can't see you," because we cannot see cystine and uric acid stones on the X-ray findings. So the first stones that we are going to discuss is the calcium stones. So calcium stones are the most common stones, making up to 80%. Among calcium stones, there are two types of stones: calcium oxalate and calcium phosphate stones. And calcium oxalate stones are more common than the calcium phosphate stones. So how calcium stones are formed? They will be formed if there is increased level of calcium or increased level of oxalate, or there will be decreased level of citrate. When there will be increased level of calcium and oxalate, they will combine together, precipitate, and form calcium oxalate stones. And citrate, what happens is that citrate is present in the kidneys. It reacts with the calcium, and in this way calcium is excreted from the urine. But if the level of citrate is less in the kidneys, it will not be able to bind all the calcium level in the urine will increase. It will combine with oxalate, and calcium oxalate stones will be formed. Means that citrate helps in dissolving and excretion of the calcium into the urine, and making less possibility of the formation of the calcium oxalate stone. So the level of citrate in the urine is also very important for the formation of the stones. So how they can result? They can result from ethylene glycol ingestion, that is antifreeze, vitamin C overdose, or hypocytraturia. What happens is that when there will be decreased level of citrate, it will happen in condition of distal renal tubular acidosis, that is known as RTA type 1. Low level of citrate is seen in chronic diarrhea, and when we increase the intake of the animal proteins, there will be less amount of citrate in the urine. How oxalate level is increased? It is increased from ethylene glycol and vitamin C overdose that metabolizes and increase the level of oxalate in the urine. Third one is the malabsorption. For example, in Crohn's disease, what happens is that suppose these are the intestines. In intestine, calcium and oxalate combine, and then they are excreted into the feces. If there is malabsorption of the fats, there will be increased amount of fatty acids in the urine, in the feces. So calcium will bind to fatty acid instead of oxalate, and oxalate will be left behind. So oxalate will go into the kidneys, and then in kidneys it binds with calcium and precipitate to form the calcium oxalate stone. So malabsorption is an important factor in the formation of calcium oxalate stones. And if we see the treatment, treatment is the low sodium diet, because if there is increased amount of sodium, all the water will be used to dissolve the sodium, and there will be no water to dissolve calcium and oxalate, and there will be increased possibility of formation of calcium oxalate stones. We can give citrate, because we have seen that decreased amount of citrate precipitate the formation of these stones, and we can give thiazide diuretics to the patient as treatment. There is an important MCQ that we give thiazide diuretics in the treatment. What thiazide diuretics do? They decrease the calcium excretion into the urine. That will decrease the chances of stone formation. We can also increase the protein intake of the patient, which will cause decrease the amount of we can decrease the protein intake of the patient, which will cause increase amount of, because decrease increase amount of protein decrease the citrate in the urine. We can also decrease the oxalate consumption of the patient, which is present in chocolate and spinach. We can increase the calcium intake, because increasing the calcium, when calcium is more, it will bind to oxalate and it will be excreted into the urine. We can increase the potassium intake, because potassium also increase citrate in the urine. And among thiazide diuretics, the example is hydrochlorothiazide hydrochlorothiazide. And the these stones are radio opaque. We can see them on the x-ray, ultrasound, and even on the CT scan. If we see the shape, the calcium oxalate stones are like envelop or a dumbbell like here shown, and the calcium phosphate stones are wedge shaped prism. Calcium phosphate stones treatment is same, low sodium diet and thiazides. They will form when the pH of the urine is increased. They in alkaline urine they are formed because of the precipitation of calcium phosphate. And one important point is that calcium oxalate stones are formed when there is increased amount of calcium in the urine. But the amount of calcium in the blood, it can be in the normal range or it can be in increased range. The important point is that it is not always important that there will be increased amount of calcium in the blood. Calcium oxalate stones are formed even when the calcium level in the blood are normal. Increased calcium level in blood is seen in hyperparathyroidism, and normal level can also cause hyper increase in level of the calcium in the urine. The normal level are 8.5 to 10.5 milligram per deciliter. Next are the ammonium magnesium phosphate stones, that are also known as two white stones. So they account for 15% of the stones, and they are caused by infection with urease positive bacteria like Proteus mirabilis, Staphylococcus saprophyticus, and Klebsiella. They are important. What they do is that they hydrolyze urea to ammonia, and urine will become alkaline. For example, what happens is that we know that there is urea in the urine. So these enzyme bacteria have urease enzyme. They cause urea to break down into ammonia and carbon dioxide gas, and this ammonia will combine with hydrogen ion to form ammonium. And we know that ammonium is basic. It will cause alkaline pH will be increased more than 7. In alkaline pH, these three salts, ammonium, magnesium, and phosphate, that will be present in the kidneys, they will precipitate and they will cause the kidney stones. Here, these stones will form. And these bacteria are important for MCQs. Urine will become alkaline, and they commonly form staghorn calculi. Staghorn calculi basically, uh, here there will be stones formation, and it will be in the shape of a staghorn. They are large stones in the form of a branching kidney stones. They don't pass into the urine. There will be no colicky pain like we discussed in the calcium oxalate or calcium phosphate stones. The pain will be there, but it will be only in the flank region. There will be flank area pain or tenderness. So patient will present with flank area region tenderness or fever due to infection because it is caused by bacteria. There will be hematuria because of the kidneys damage. The patient can present with nausea, vomiting, confusion or dysuria. All the UTI signs and symptoms we will see because it is caused by the infection of the urinary tract. And another important thing is that because they are large stones, urine will not be able to pass, so there will be urine stasis and there will be repeated infections. Due to the repeated infections and chronic obstructive nephropathy, the kidneys will undergo atrophy. So we will see kidney atrophy in these patients. And they are also radio opaque, means that we can see them on X-ray, ultrasound as well as on the CT. And the important point is that they are formed due to increased pH. Solubility doesn't matter. What important is that the pH should be increased more than 7. And on urine analysis, the crystals we see will be like a coffee lid, sarcophagus, in the form of a coffee lid. If we want to treat this, we will give antibiotics to treat the infection, and we can decrease the pH of the urine, but they are large, they cannot pass, so we have to remove them surgically. So that was all about ammonium, magnesium, phosphate, that are also known as true white crystals. Next one are the uric acid stones. They are formed when the pH of the urine is less than 5.5, means they are formed in acidic pH. They are radiolucent, means we can see them on we cannot see them on the X-ray, but they are visible on the CT scan. And the crystals will be rhomboid or rosette shape like the shown here. On urine analysis, we will see these crystals. They are about 5% of all the stones. Risk factors include arid climate and acidic pH. If we see, they are formed in close association with hyperuricemia like gout, often in diseases in which increased cell turnover like leukemia. What happens is that we know that DNA is present in our cells. When there will be breakdown of these cells, there will be release of purines and pyrimidines. When there will be breakdown of pyrimidines, they form uric acid, and uric acid is then excreted into our urine. When there will be increased breakdown of the cells, increased cell breakdown, there will be increased purines and increased uric acid synthesis. What happens is that the uric acid forms urate crystals in the presence of acidic pH. When pH will be less, the uric acid will be converted into urate crystals, and acidic pH means there will be increased amount of hydrogen ions. So these uric acid urate combines with the hydrogen ion and form more uric acid, and this uric acid precipitates and it forms the uric acid stones in the urine. If we see, increased water is required to dissolve this uric acid and to excrete it into the urine. When there will be decrease in water intake, there will be precipitation of uric acid stones. So the people who are living in arid climates like in hot weather, there is increased amount of sweat production, and this will cause dehydration into our body due to water loss. In patients who have diarrhea, there can also be decrease in water, and this can cause formation of the uric acid stone. So risk factors include arid climates, hot weather, and acidic pH that precipitate the urate crystals formation. In hyperuricemia, obviously there will be increased level of the uric acid, and when there is leukemia like the WBC cancer, there will be increased turnover of the cells, increased purine synthesis, and increase in the uric acid crystals formation. And an important MCQ is that the uric acid, overall the calcium stones are the most common stones, we saw it earlier, but uric acid stones are the most common stones of the urinary bladder. And if we see the treatment, we will cause the Linization of urine, like by giving potassium citrate, so there will be no precipitation of the uric acid or urate stones. And we also can give a drug known as allopurinol. Allopurinol, basically there is enzyme xanthine oxidase that convert purines into uric acid, and allopurinol is xanthine oxidase inhibitor. When we will give this drug, there will be no production of the uric acid, and so we can prevent the formation of the urate stones, urate crystals. The last one are the cystine stones that also precipitates in less pH. On X-ray, they are faintly radio opaque, and on CT scan, they are moderately radio dense. They are hexagonal urine crystals, like shown here. And this disease is hereditary, autosomal recessive condition in which the cystine reabsorbing PCT transporter loses function, causes cystinuria. They also result in poor reabsorption of ornithine, lysine, and arginine. We have to remember these four amino acids by the mnemonic cola: cysteine, ornithine, lysine, and arginine. So cysteine is poorly soluble and the stones form in the urine. And its important feature is that it typically begins in childhood. It can also form staghorn calculi, and we can confirm the presence of the crystals by doing sodium cyanide nitroprusside test. What happens is that we know that after the Bowman's capsule there is proximal convoluted tubules in which the amino acids are reabsorbed. When there is defect in PCT transporter, these amino acids, particularly these four amino acids, are not reabsorbed. And the cysteine is also a amino acid. It is not reabsorbed due to a autosomal recessive condition in which cysteine reabsorbing PCT transporter loses its function. So cysteine is not absorbed, it is excreted in the urine. Cysteine precipitates in the acidic pH and form cysteine stones, and it is characteristic of childhood. The difference between the staghorn stones of the struite and the cysteine stones is that the struite stones occur in the adults while these occur in the children. Treatment includes low sodium diet, alkalization of the urine, and using chelating agents like triopronin and penicillamine. What happens is that these chelating agents absorb cysteine and other amino acids, and they remove them from the urine, don't allow the formation of the crystals. If there is stone formation, we will see dilatation of pelvises, calyces. Ureter can also be dilated, and on urine analysis, we will see free red blood cells. While in glomerulopathies, we saw the RBCs were in the form of casts, while in the case of in kidney stones, we will see free red blood cells in the urine due to hematuria. So that was all about kidney stones, in which calcium stones are most common, then struvite, then uric acid, and the cysteine stones are the least common.